Hey, this is DocTalk Live. I'm Dr. Brad Goodman. I'm with Brian McCool.
How you doing?
Brian, thank you so much for doing this today.
Appreciate the opportunity.
Dr. McCool is an ear, nose, and throat specialist, and we're in his office.
Right.
And so I deliberately wanted to stand here because there was this picture here of the stuff you
ENT
do.
stuff.
So maybe you could give us a little tour of
sure.
this poster, and then maybe we can hit topics based on that. Would that be okay? And if
Sounds
there's
good.
questions, if people are watching live, great. If not, if they catch it on the refeed, they can type in some questions later, and maybe I can get you to answer them later. But go ahead, give us a tour of the poster here.
Sure. So the field is, you've probably heard of ENT, ear, nose, and throat doc. It's actually ear, nose, and throat, head and neck surgery. So it's a pretty broad field. Obviously, ear, nose, and throat. And then
Everything but the brain.
everything outside of the eyes and the brain. That's what I tell folks. We turn that over to the ophthalmologist. As a historical note, I think 70, 80 years ago, it was double ENT. Ear, eyes, nose, and throat. Eyes went one way, we got the rest of it. Anyways,
Interesting.
so head and neck cancers, thyroid cancers, all that training in residency, and we still do a fair amount of head and neck surgery as well. But as far as this, obviously ear, nose, and throat, what this top left shows is kind of a cutaway of the inner ear. So basically, if you
can use me as a model if you need to.
So if I cut down the barrel of the ear canal, which I know sounds kind of rough, but nonetheless, that's what this is showing. And so we consider the outer ear not just the ear we see, but also the ear canal down to the eardrum. That's the outer ear.
Okay.
Middle ear is eardrum and the little air pocket behind it. That little air pocket is connected to your nose via the eustachian tube. So that's the tube that allows our ears to pop when we go up on a mountain or airplane.
Mm-hmm.
This is the little tube that causes all the problems mainly in young kids. So if they're getting ear infections, this tube isn't opening up enough to air out the space behind the eardrum. And so if we go a little bit further, so that's the middle ear, and it has those three tiny bones that you heard of. Hammered.
Here's the stirrup, right?
That's correct. So the malleus
and the anvil. There's the anvil,
there's
right?
the anvil, hammer, anvil, and stirrup.
Okay.
We call it malleus, incus, and stapes.
Okay. Y'all have the coolest names, by the
They
way.
are, and it's tiny. I mean,
Okay.
this is really tiny stuff. So the inner ear is actually where all the magic happens. So this snail-looking thing right here, there is a hearing portion which is called the cochlea, and a balance portion called the semicircular canals.
So this is the cochlea. These are the semicircular canals.
Right.
Okay.
And so what this is trying to show is this is bone here. This whole thing would be covered in bone, actually embedded in the bone of the skull. So we can't really see it, obviously, when we're here in the clinic, but that's kind of how we break it down. Outer ear, middle ear, and inner ear. So this cochlea is the organ where it's a pretty cool gizmo. It's a transducer.
What did you say?
It's a cool gizmo.
What?
Gizmo.
I'm teasing.
Transducer.
So this has a lot to do with hearing, right?
It does. It takes the mechanical wave. So the ear canal is shaped like a funnel. The outer ear that we see is shaped like a funnel, directs the sound waves that hit the eardrum.
Mm-hmm.
These three tiny bones are organized in such a way that they amplify the vibrations. And if you think about it, it's a big surface area here, big surface area here on the eardrum, and then the foot of the stapes that's connected to the hearing organ is very small. So all that energy gets transferred down to a smaller area and kind of amplifies it. So the inner ear is really neat. It's laid out, it's curled up, but if you think of a piano, on my left hand, bass notes,
Mm-hmm.
right hand is the high notes.
Right.
So all the different frequencies coming in stimulate different parts of the cochlea, from low tones to high tones. It's pretty cool. And then what
would be the corollary in the musical world? What's like the cochlea in the musical instrument world?
I see. I do think the piano is a good example,
Okay.
because if you took the piano and kind of rolled it on itself into a a rounded thing.
Into a nautilus, yeah.
Mhm. And so it takes those mechanical waves, changes it into a electrical signal that is then carried on the hearing nerve to your brain, and then your brain figures out, hey, what is that sound that was just delivered? So it's a pretty amazing.
Wow. So it's like a miniature piano
Exactly.
that delivers delivers that to your brain.
Exactly.
And what are some of the more common dysfunctions that you deal with, like hearing loss? When do you need a hearing aid?
Sure.
How does all that work?
So the majority of hearing loss is probably age related. So as we get into our 6th decade of life, that's when we will really start noticing, a lot of folks will start noticing that there can be a decrease in hearing. And it's a slow, subtle process. I talk to my patients a lot. I'll have them look out the window, and to me, that tree across the road is a pretty green, blobby thing because I don't have good vision. It's pretty obvious that my vision there's something wrong.
Right.
Hearing loss is usually a slow, subtle process over the course of many years, and so it's almost as if you're not aware of what you're missing.
And what is that slow, subtle process?
Gotcha. So in the inner ear here, we have these tiny hairs that some people have probably heard about, and you can get damage to those tiny hairs. Those tiny hairs are organized along that piano that I was talking about. Some are responsible for the low tones, some for the mid tones, some for the high tones. And over time, it's the high tones that'll just essentially degenerate. We lose those tiny hairs, so we lose high frequency nerve hearing loss.
And so what do you do about that?
Well, if it gets to a certain point, got to probably come in and get it. All hearing loss should be checked out. I mean, we got to make sure that it's not some sort of medical problem. Not common, but people can get little growths on the hearing or balance nerve that can cause hearing loss. But once hearing loss gets to a certain point and it starts impacting mainly socializing. So we'll get a lot of complaints about spouses saying, my spouse doesn't listen, and that person will say, well, she's not talking loud enough, or vice versa. So it can really impact socializing. And when it really, and then we also talk about difficulty using the phone. Maybe it's hard to hear the television, or the TV's up really loud. And what a lot of people don't realize, it really is, can be, really cause a lot of social problems.
It sounds like you treat this with a hearing aid, though.
Yeah, absolutely. You're getting onto it.
And it sounds like, well, my recollection of hearing aids is people don't really like them. People don't take to them all that well.
And so it gets to that certain point, then it's nerve loss, right? So there's no way to repair that nerve. So we call it amplification or hearing aids. And I would say in the past 10 years, certainly the past 5 years, they've gotten so much better, mainly at suppressing background sound and preferentially picking up on human speech. They're tiny little computers that are programmed to pick up speech over the background sound. So basically, you got to get more, the hearing aid would fit down into the ear canal, and then it just increases the sound waves, the decibel level, the loudness to the eardrum, and basically will allow people to hear so much better. And it really is, it's nerve hearing loss, so there's not a whole lot else to do about it.
Okay. Well, if you're just tuning in or if you're listening to a rebroadcast, I'm with Dr. Brian McCool. Dr. McCool's with the McCool and Bhuta Clinic, right? Ear, nose, and throat. This is DocTalk Live. This is a conversation.
Sure.
I'm generating the conversation. If there's questions, though, please type them in. Maybe Hunter can grab them or not. But if you're seeing the rebroadcast, because you know this will show later on, if you have questions, by all means try to type them in. So let's maybe move to the sinuses.
Sure.
Yeah, would that be
Sounds
all right?
good.
Okay. So talk to us about this guy here.
So we're actually not born with most of our sinuses. We have little sinuses which are air-filled cavities surrounding the eyes. And when we're born, really the only ones we have are these tiny ones that are behind the cheekbone. But as we grow and our skull grows, we develop the sinuses that surround the eyes. And this picture here shows below the eyes, above the eyes, and in between the eyes. If we kind of take a sideways view, we can also see that there are some sinuses that are essentially deep to the eyes. So I get asked a lot, what are they for? Good question.
What are they for?
I think my theory that I like is that we experience the world face first, right? We're usually walking forward and we're in our environment face first. It's like a lattice structure. So if we have an injury, we take a blow to the face. And it sounds terrible to say, but the bones will collapse, will fracture, and it doesn't transmit all that energy to our brain. So I think it's probably a little bit of a safety mechanism.
Interesting.
Right? Some people think it lightens up the weight of the head. Instead of it being all solid bone, maybe it makes our head a little bit lighter so that our necks that are on this, like my neck, thin neck, it's not so much a weight to support. Anyways, they're lined with what's called mucosa. It's the skin on the inside of our nose and our mouth, and mucosa produces mucus. Even in times of health, we're producing this thin mucus. It has antibacterial properties, kind of keeps all those air pockets from getting infection. And it sounds kind of terrible, but that mucus makes its way to the back of our throat and we swallow it. It's just in times of sickness that it'll thicken up and get goopy and nasty. Probably don't want to be swallowing that stuff. And so,
is that what causes the sore throat?
I think it can be a real big cause of sore throat. That post-nasal drainage, or the drainage draining down the back of the throat, can irritate the throat. We see that a lot, not only in infections, but we see a lot of folks with allergies. So allergies chronically inflame and irritate all of this lining, and it produces more mucus that can go down the back of the throat. It's interesting, the maxillary sinus is what the one behind the cheek is called. The frontal sinus is the one that's in the forehead, and they're basically pretty broad and funnel down to a narrow outflow tract into the nasal passages. A little hard to see on this diagram, but that can be the real problem, is that it's almost like a pressure valve that gets closed down, and that can back up a lot of the mucus into the sinuses. You can get chronic infections.
And it seems like if you look at if we were in a pharmacy right now, I would say that there are so many drugs that are geared toward sinus.
Absolutely.
And drugs, what should our viewers know about these drugs?
So I think if you go there, the things you're looking for, anytime you see D, it usually means Sudafed. And nowadays you have to, it's not prescription, but you have to sign your name for Sudafed.
Right.
They'll only dispense.
Because it's diverted, but
correct.
But it does the job.
It does. So people, you're taking a pill, you're getting potentially systemic effects from it. So you got to be careful, folks who are hypertensive, maybe have some arrhythmias, maybe have some anxiety. You're taking a pill systemically, it can kind of get you revved up. So a lot of people will go to the nasal decongestant sprays. Afrin is the name brand. Maybe I shouldn't say that.
No, that's fine.
Oxymetazoline is the active ingredient, and then there's phenylephrine that's in neosynephrine.
Okay.
I think they're fine, but you got to stick to 3 or 4 days, right? They're topical decongestant sprays. You can avoid the systemic effects of Sudafed, and I think they work great. The problem is I think sometimes they work too good. People get pulled into using it more and more, so it starts causing the problem that it's also supposed to take care of. The interval of relief goes from 8 hours to 6, 5, 4, 3, 2, 1. So some people get wrapped into using it more and more.
So those are the ones that are addictive.
Yeah, and I think addiction, and I'm not
habit forming. How about habit
there
forming?
There you go. I don't think there's a physical addiction. It's just that it's caused the congestion. I need to use it again. Well, guess what? 2 hours later, it has caused the congestion. So you get pulled into using it more and more.
So when does somebody need surgery? And what is this? It's called balloon sinuplasty. When does somebody need you to step in and do something?
Usually when it's kind of a chronic sinus problem. So we say 12 weeks of symptoms, and a lot of times it's facial pressure and pain, and what I call this hourglass shape, kind of broad, and it kind of follows these sinuses, broad, narrow sinuses in between the eyes and broad above the eyes. A lot of people have pressure and pain, nasal congestion, a lot of thick drainage out of the front.
So what do you do?
So if they tried I think oral antibiotics have a role there. The problem is I think a lot of people get put on antibiotics maybe too often. It may be allergies, so we always want to make sure there's not an underlying allergy issue. Chronic infections, a lot of antibiotics, we're usually getting a CT scan, and I don't know if folks are familiar with that. I tell my patient, and it sounds kind of rough, but it takes pictures of your head like a deck of cards or maybe like a loaf of bread.
Right.
Picture through the tip of your nose, and then a little further back, and then a little further back. So just like on a loaf of bread, you could pull down each slice and look down the face of the slice. We can evaluate the sinuses, and if it looks like there's a bunch of backed up mucus there, or interestingly enough, sometimes people don't have a lot of backed up mucus and infection, but that narrow outflow tract that I was talking about, and that's where that balloon sinuplasty has been very effective.
What does the balloon do?
So basically, they took the cue out of the cardiologist handbook, and I think that's the history of it. About 20 years ago, there was an ENT who was a cardiologist who was having a lot of sinus issues, and he said, why can't we do something similar? So although we don't leave any stents behind or balloons behind, it is a device that will go into the nose, and you can get it into that narrow passageway and actually dilate that passageway. So There is very thin bone. It's not like having a rhinoplasty. There's no bruising, but it does kind of push the walls of the room open. I tell people it kind of gives you a permanent decongestant so that you don't need Sudafed, that you don't need Afrin. And for facial pressure and pain and nasal congestion, it's been fantastic.
I want to plant some seeds, okay? Go, Hunter, you have something for
I
me?
just have one question. It's how many rounds of antibiotics for ear infections do you think are typically you see before tubes are necessary?
God, that's a great question. 10, 12 years ago, it was quite a few rounds of antibiotics. I think seeing some of the effects that antibiotics can cause, gut disturbance and all that sort of thing, somewhere around 3 or 4, right? I would say 3 or 4, especially if a child has gone to a series of Rocephin shots. So if they failed oral antibiotics, sometimes they'll have like 3 Rocephin shots in a row. If it's gotten to that point, I think the tubes in the child's through the eardrum. So what we'll do is, we can do it on an adult here in the chair in the clinic. Child won't stay still, so we get them in the operating room. We look down the barrel of the ear canal, and we can make a tiny incision in the eardrum. If there's any infection fluid behind the eardrum, we suction it out. Can I borrow your pen?
Oh, sure.
So we put a cylinder, a tube, and it's really only about as big as the very tip of the pen, through the eardrum. So now air can come from the ear canal side to keep the back side of the eardrum dry. Great stats on it. About 70% of the kids won't get another infection. If they do, they usually don't have the pain and discomfort associated with it because that tube will allow it to drain out of the ear. We've got an indicator. We see that drainage. We know it's an ear infection. And then finally, we can treat it more effectively with topical drops as opposed to more oral antibiotics. Long answer, I would say somewhere around 3 or 4 rounds of antibiotics.
Brian, I'm gonna leave it there if that's okay, Hunter. But I want to say a few things. Brian, you're amazing. I appreciate you so good at explaining this stuff.
Sure.
I want to set us up for another show,
Sure.
which is to say that personally, I would love to see some images on your computer.
Okay.
Maybe you could take us through
Yeah,
a sinus surgery through a video that you may have.
videos, and we can show folks that that balloon sinuplasty procedure because it's been pretty.
I want to see
amazing.
these hairs in the
Yeah.
cochlea.
Okay,
I
sure.
want you to show me some cool pictures.
Yeah.
But also I want you to be thinking of various topics you might want to address in a very focused way. And then if we can get a date and far enough out where people
Sure.
can prepare, they can know, hey, Brian McCool's coming back. He can explain just about
Yeah.
anything when it comes to ENT. That'd be awesome.
Love it.
Brian, thank you so
Hey,
much.
thanks so much for the
Enjoyed
opportunity.
it. Loved it.
Appreciate it.